You guys want to eat first or start?
Do you want a sandwich?
No, I'm
You
okay.
ready first?
Thanks. I'm all right. So it's up to you guys. Should we just start? You want me to? So I'm Anas Obeid for those who don't know me. Cardiologist. I work out of McLaren Bay region. I live in Bloomfield Hills. And so this is the second time I give a talk. Last year I gave a talk on aortic stenosis. So I've been asked to give a discussion today on some sort of common topic that might be of interest to the general public in terms of heart disease. And I felt like there's a lot going on with cholesterol. I mean, there's, in terms of therapies and what's new, what's old, what's controversial, and a lot of data you hear is a bit conflicting at times, and that creates a lot of controversy, and a lot of times we see that in the media, and that hinders a lot of our work, because a lot of times we try to relay a certain message, and then especially with social media and whatever you hear on the news, sometimes that could be conflicting, and a lot of times patients are caught in the middle and they don't know what to believe and what not to believe. So I thought I'd shed some light mostly on therapies. I didn't want to bore you with the pathophysiology of how a cholesterol plaque is formed and how it can relate to other problems. But what I thought would be most applicable would be, well, how does cholesterol play a role in cardiovascular disease, and what do we do about it? Because if you know from whenever you see the doctor and they do an annual physical, when they tell you your cholesterol is abnormal, there's total cholesterol, there's HDL, there's LDL, there's triglycerides, AP, little a, B particles. And so what is clinically relevant, what is completely irrelevant, and what are the therapies out there that may be beneficial? And so that's why I thought this would be an applicable conversation. I didn't want to bore you with topics or discuss your lunch by giving you nasty pictures like this when you have this is a patient who probably didn't do very well, and he has a heart attack that has caused that necrosis, that scarring of the wall there. This is what a blockage would look like in a coronary angiogram, and what I would see in the cath lab, and what we fixed with stenting. You don't want to have strokes associated with this unfortunate patient as well, and that could be associated with plaque formation. So plaque formation, what I want to get across today, is not only about cholesterol, and cholesterol does play a role, but there are plenty of other risk factors that can play a role. So I didn't want to, and this is an MRI that shows a stroke, I didn't want to get too deep into the pathophysiology of all of that. What I want to talk to you is, what do we do about this? How do we prevent this? There is a huge paradigm shift in medicine in general about more of preventative medicine, primary prevention, as opposed to what we call secondary prevention. Secondary prevention is having some sort of an event and preventing another event. Well, we don't want to deal with secondary prevention. We want to deal with primary prevention. We want to avoid ever having a nasty blockage in a carotid artery like that. We don't want to have a scar in our brain or the heart like that. And how do we prevent that? Well, there's a lot of risk factors associated with heart disease. About half of the population have at least one out of the hypertension, smoking, and high cholesterol. At least half of the US population. So a lot of people are walking around with significant risk factors for heart disease. But amongst them, the most commonly, hypertension, age. I have a lot of patients that they'll come to me, and if they come in with a heart attack, they'll be like, "Doc, I work out, I exercise every day, I have my cholesterol and everything," but they're like 70-year-old male. I'm like, that alone is a risk factor. And there are some risk factors that are just non-modifiable. We can't modify them. So of course you can't modify your age. You can't modify your gender. I didn't add gender there. You can't modify family history. So some of those we're just born with, and what we try to modify are other risk factors, which include, of course, smoking. That's a huge public health issue. Most people, when they think about smoking, they worry about lung cancer, they worry about emphysema, but I try to relate that smoking really wreaks havoc on the entire cardiovascular system. Smoking, just like other drugs, can accelerate the process of developing blockage. I can't tell you how many patients I've treated with heart attacks with patients in their 30s, and their only risk factor essentially was smoking. when I see a young patient before, less than like 40 or 50, usually it's either family history, smoking, or diabetes. But smoking plays a huge role. Diabetes, again, chronic kidney disease. Now, sedentary lifestyle and obesity is more of an indirect cause of heart disease, because generally speaking, if you're sedentary, you gain weight, that can increase your blood pressure, your cholesterol. If you're overweight, that's a risk factor to develop insulin resistance and diabetes, which can then lead to further heart disease. So it's more of an indirect cause. So when you see your family doctor or your cardiologist or whoever, and they run a physical on you, a lot of times they check your cholesterol panel. These days we don't focus very much on total cholesterol. A lot of times people focus on total cholesterol, but that can be affected by the HDL and it can be affected by the LDL. So we mostly break it down and focus on the individual points like HDL, LDL, and triglycerides. The HDL is the good cholesterol. So think of it as H, you want it higher. So we want high HDL. That's a good cholesterol. The LDL is the bad cholesterol. We want it lower. That's the lousy, the lower. That's the toxic particle. That's what most of the cardiac clinical trials have been focusing on, mostly lowering the LDL, because that is what's been shown in clinical trials to have the most benefit, really in both primary prevention and secondary prevention. It's not that HDL and triglycerides don't play a role. Actually, if you have low HDL, that's associated with increased risk of heart disease. If you have high triglycerides, that's also associated with increased risk of heart disease. The reason why we don't focus on it very much is mostly because we don't have very good therapies for HDL and triglycerides. And LDL lowering, though, in our clinical trials have been shown to be remarkable in terms of their efficacy. So what to treat, what not to treat. And so how do we raise the HDL? I told you that low HDL is associated with increased risk of heart disease. So how do we raise the HDL? Are there any medicines that raise the HDL? In fact, there is. One of the most common ones is a vitamin. It's a vitamin B particle. It's called niacin. And we used to use niacin to raise HDL, but that's fallen out of favor because we found in clinical trials recently that really there's no benefit. So all niacin will do is increase your HDL. It will make your numbers look pretty on paper, and that's pretty much all it will do. And so even though it will definitely increase your HDL, but that hasn't translated into lowering your risk of heart disease. And that's what we want. We want outcomes. We don't only want our numbers to look good on paper, we want hard outcomes. And so niacin has completely fallen out of favor. Actually, some clinical trials may show that there could be even more side effect than benefit to the niacin. There are some other clinical trials going on right now to see if other medications can increase the HDL, can have that benefit. And they're still in the process of being conducted, but a lot of them showed promise. Some of them were withdrawn because they had too many side effects. But right now, there's really no good therapy for increasing the HDL, the good cholesterol. So what do we tell patients? The best way, does anybody know, to increase the HDL is just exercise. Yeah. Certain wines have been associated too with increasing your HDL, but probably the best thing is just keep on moving. And that's the best way. Better than any medicine can offer is to just keep moving. So what about triglycerides? Is there a benefit to lowering triglycerides? So by the way, HDL, generally speaking, we like it above 40. And the triglycerides, generally speaking, we like it under 150. So are there any good therapies? There are actually a couple of classes of medications that we can use to lower triglycerides, but it's actually the same exact problem with the medicines associated with the HDL. So we have a lot of medicines that can make your numbers look really good on paper, but unfortunately, same thing. It hasn't translated into lowering the risk of heart attack or stroke or dying. So it's not that we ignore triglycerides by any means. It still is an independent risk factor for increasing your risk of heart disease. But what do we do about it? We do more of the lifestyle changes, just like the HDL, as opposed to using medication. So Yeah.
So if they have you on triglyceride medicine, is it really not that great then?
Not that it's not great. It's not that we never use it. There are certain situations that we will use medicines to lower the triglycerides, and I usually do that when this patient has very high triglycerides. Like if they're above 500, now you're at risk for other problems. Sometimes people can get acute pancreatitis if their triglycerides are severely elevated. So then, yeah, that case. So I'm not really doing it because I'm going to think it's going to lower the risk of a heart attack, but it probably won't. But at least it may reduce the risk of other problems. So how do you lower triglycerides? The number one thing is watching the white stuff. So anything that could be white, carbohydrates, simple carbohydrates, rice, potatoes, breads, pastas. Those are all the good stuff. So
Everything good.
everything good. So that's why I try to relate patients. It's impossible to tell people to eliminate that stuff, and because it's nobody's going to listen to you. But minimize, eat more of the lean, healthier stuff that won't lead to such. Well, why do carbohydrates cause high triglycerides? Especially simple carbohydrates. When you eat them, they are very quickly absorbed into your bloodstream. And so what happens once all that glucose gets absorbed into your bloodstream, your sugars go up, and the body doesn't like high sugar. So what happens is your brain stimulates to secrete a lot of insulin to get rid of that high sugar. So what does insulin do? It takes that sugar, stores it as fat. Your triglycerides go up and people gain weight. That's why carbohydrates are problematic. That's why, like in the 1990s, if you guys remember, there was this huge fat-free craze. Everything in the grocery store was fat-free, but everybody was gaining weight. Is because they took out the fat from the food and they substituted it with sugar for the flavor. And so people had high carb, low fat. Everybody was gaining weight, thinking that they were being healthy, eating all this non-fat, low-fat food. So one of the best ways, to lower the triglycerides would be to watch just anything that has high carb. So sugary drinks are probably the worst. I tell people don't drink your calories. So minimizing sugary foods, alcoholic beverages. There are actually certain medicines too that can increase your triglycerides. So if you have very high triglycerides, you need to sit with your doctor and go over the list of your medication to make sure you're not on any certain, specifically diuretics. Certain diuretics can increase your triglycerides, and simply withdrawing that can cure that. But because if you have very, very high triglycerides, sometimes that's an early marker of diabetes. So just make sure you sit with your family doctor and discuss, and make sure all the T's are crossed and I's are dotted before you just start medication. Just like HDL, and there are some clinical trials, again, in the process of being evaluated, because we still know that triglycerides, high triglycerides, it's a risk factor for heart disease. So there must be some sort of therapy that we can offer to lower that risk of heart disease. So they're still being conducted, some clinical trials being conducted to see if we can lower that risk using medicine. We don't want medicines that just make numbers look good on paper. We want medicines that will translate. We want to, of course, make sure that they have a effective or a safe, good safety profile, and at the same time, outcomes. We want to make sure that these medicines can lower the risk of having a heart attack, stroke, or dying. And that's what leads us to statins and the LDL. So why are statins so beneficial? And there's actually a lot of controversy over that. And I think a lot of the controversy out there is problematic, because it creates a lot of confusion in the public, in the community, and people actually stop taking their medicines because of what they hear. And it's unfortunate, because statins is not, they don't only make your numbers look good on paper. They don't only lower the bad cholesterol. Statins have an anti-inflammatory component to them. And if you look at that first picture I showed you, that ugly carotid blockage, it's not, like I told you earlier, it's not just cholesterol. If you look at the process of developing blockage, one of the main components is inflammation. And if we could lower that inflammatory process, then we could stabilize blockage. We could prevent a blockage from causing a stroke, from rupturing and causing a heart attack. So that's where the major benefit to statins play a role. Actually, statins now, you know, historically, when did we prescribe statins? Historically, I would check your cholesterol. If I didn't like your numbers, I'd give you a cholesterol medication. for the most part, that has completely changed. It's not about the numbers anymore. It's more about risk factors. It's more about your history. So there's 4 general categories of patients who should be on a statin, really regardless of where your numbers are at. Number 1 is if you've had any sort of cardiac history. So if you've had a stroke, you have coronary artery disease, heart attack, stents, bypass, any documented cardiovascular disease, it really doesn't matter where your cholesterol is. Apparently, even if your cholesterol number is normal based on the general population, it's not normal for you if you're developing these blockages. And again, the key is once you've developed this cardiovascular history, is you want stability. You want to stabilize your cardiovascular system. You want to stabilize blockages. And statins help lower the LDL, which is the main toxic particle, and then also the inflammatory process that we're talking about as well. So the first category for patients who should go on a statin is cardiovascular history. And a lot of times I deal with patients, they come in with a heart attack, and a lot of them come in and they've never been on any medicine. And when I tell them you should be on a cholesterol medicine, they question it as to, well, I have normal cholesterol, doc. Well, things have changed now. Now that you've had a heart attack, you should be on the statin. Second is diabetes. So really, even if you're a diabetic and your cholesterol is normal, we think of diabetes as a cardiovascular equivalent. It's almost as if you've already had a cardiac event. That's how we think of diabetes. Diabetes is an ugly beast. It really accelerates the process of developing blockages and renal dysfunction and cataracts and eye problems, kidney problems, everything. It really wreaks havoc on the entire body, but specifically the cardiovascular system. So a diabetic, whether they have heart disease, whether they don't have heart disease, or they've had normal cholesterol, they should be on a statin. And the third category, the only time we really focus much on numbers is if the LDL is severely elevated. So if somebody has a severely elevated LDL of 190 or higher, that's an indication. Even if you don't have diabetes, if you don't have cardiovascular disease, if your LDL is severely elevated, greater than 190, that is a genetic predisposition, and you should consider a statin. The fourth is there's a way to calculate your cardiovascular risk score. Actually, the American Heart Association has created a calculator based on your age, your blood pressure, what medications you take. You could actually get online and do it. We have apps on our phone to be able to calculate a 10-year risk score. What is your risk of having a cardiac event over the next 10 years? And if your risk is high, and by high I mean if you have a 7.5% chance of having a cardiac event within the next 10 years, that is considered high risk, and that is an indication to start a statin. So it's a risk calculator. Do we frequently spend enough time with the patient and calculate everything? We don't. We probably should. But if we feel like a patient does have multiple cardiovascular risk factors, we may consider running a risk score on them, and if they fit that profile, then we put them on a statin. And so what kind of therapies? The number one focus to lower the LDL. There's other medicines besides statins, but the statins again have that inflammatory component, which is why they are so highly recommended. And any medication can have potential for side effect, right? And everything in medicine is weighing the risks versus the benefits. Heck, if we want to give somebody a Tylenol, we need to weigh the risks versus the benefits. And can statins increase your sugars a little bit? They can. Can they cause diabetes? It's not that they can cause diabetes, but if somebody's like pre-diabetic and borderline, can it tip them over the edge? Potentially. But even despite that slight increase in sugar, that overwhelming benefit would outweigh that risk. So if somebody has sugar diabetes or they're in their borderline, it doesn't matter. Even if their sugar or their hemoglobin A1C goes up even a little bit, the overwhelming benefit of that medicine will outweigh that incremental increase in their sugar. And they could treat the sugar out with other therapies. For a long time, they were concerned that statins can cause dementia and neurological dysfunction and hemorrhagic stroke, and a lot of the clinical trials have shown that really the statins are very safe and there is no increased link. I've had a lot of patients where we love it. We see their LDL drop extremely low, like into the 20s and 30s. And family doctors and neurologists are all worried and telling them to see your cardiologist right away because your LDL is too low. clinical trials have shown that there really is no too low. There's a brand new class of medicines, which I can talk about here in a second, that have a tremendous capacity to lower the LDL and have shown no sequela or consequence to lowering the LDL. There is no too low. So right now, the American Heart Association, they recommend if somebody has heart disease to get the LDL below 70. And with some new therapies, we see the LDLs even into the single digits. And not only are these patients doing better, but they're not having any consequence or any side effect of having a too low of an LDL. So I wouldn't be surprised, probably in the next several years, that the American Heart Association will probably change their recommendations. And soon we'll have goals of less than 50, and who knows if even less than that. Because these newer therapies are showing so much promise. Not only is the LDL going down, but as the LDL goes down, the outcomes are getting better. So less heart attack, less stroke, better survivability. Some of the best landmark cardiology clinical trials have all been with statins and showing the benefit. Actually, certain clinical trials using statins in patients who've never had a heart problem, in patients who have normal cholesterol, and still showing benefit in terms of lower risk of heart attack. We joke around, you know, how they say, you know, fluoride, there's fluoride in the water, we say we should put statins in the water just because of how much benefit we see. Now, of course, everything has potential for side effect. Can everybody tolerate a statin? No. One of the most common side effects, muscle aches and weakness and cramping. And I can't tell you how many times I've had to switch statins around just because some people tolerate one statin better than the other. So if somebody doesn't tolerate statins, or we don't get the reduction of LDL that we like with statins, we have other therapies. There's a medicine called Zetia. It lowers cholesterol in a different way, specifically the LDL. So we use it in conjunction with statins, and it helps reduce the LDL, and actually been shown in clinical trials to reduce heart disease and stroke as well. So there's a brand new class of, well, relatively brand new now, a class of cholesterol lowering medication, or LDL lowering medication. And they're actually injectable, kind of like how diabetics inject insulin, but it's only one injection every couple weeks, so a couple injections a month. And those are the medicines, actually they're supposed to be used along with statins, have been shown to have a tremendous capacity to lower the LDL. And I've had some patients in the single digits and teens, and they do remarkably well, really, in an effort to stay. Again, what we're looking for in cardiology is stability, and we want stable. If somebody has blockage, if somebody has history of stroke and coronary disease, we want to stabilize blockage and make sure that these blockages don't proliferate. It's always been thought that atherosclerosis, like the process of developing blockage, is a progressive disease, and we want to halt that progression. We want to definitely slow it down, but if possible, halt. A lot of people will ask me if I have like a 50% blockage, well, will it ever go away? And like I said, historically it's always been thought of a progressive disease. I don't really need a 50% blockage to go down to 40%. I just don't want it to get any worse. But really, with high doses of statins, and I wouldn't be surprised soon with these new injectables, that perhaps we will see a regression and plaque getting smaller. But again, the key is we just want stability. We don't want any blockage getting worse with time. And it's not only through LDL lowering, it's really addressing every single risk factor that you saw on that first slide that I had. So adequate blood pressure control, exercise, avoiding sedentary lifestyle, avoiding smoking, and things that may accelerate that process of developing blockage. So those injectables, there's two in the market right now. One of them is called Repatha, the other one's Praluent. They're very expensive, they're brand name, they're in the thousands. Insurance companies give us hell really trying to get them prescribed for patients. But they're applicable for people who can't tolerate a statin. They've tried a few statins and they just have severe muscle aches and they can't tolerate them. Or if somebody's on a high dose statin and their LDL is still not at goal. So again, the goal is less than 70, right? So let's say you have somebody on Crestor 40 and their LDL is still above 70. So if that is applicable to you, then that is actually a consideration and you may benefit from further therapies. So what I'm trying to get to, a lot of times we focus more on procedures and devices when really medical therapy alone goes such a long way, not only in cardiology, probably in general, in medicine in general. And although we have better pacemakers these days and better stents these days, still nothing beats making the right lifestyle changes and a good medical regimen. And studies have shown if somebody, let's say I have like a 90% blockage in one of my arteries, if I live an active lifestyle and I have no symptoms, that blockage should not be touched. I should be on the right medication, and that blockage, in the setting of a stable patient. If somebody has a heart attack, that's very different, or if somebody has a very high risk feature. But if somebody is stable and they're active and they have no symptoms and they have a blockage, actually we could be faulted for stenting them, because studies have shown that medical therapy is just as effective as putting in stents in these kind of stable patients. The only benefit to putting in a stent and a blockage like that would be to reduce symptoms. So if the patient doesn't have symptoms, you just pretty much offer them nothing. So that's why it's important to make sure that patients are always on an optimal therapy, because that has been shown to be just as effective. Of course, in the setting of a heart attack, that's very different. But exercise, activity, modifying the risk factors, being on the right medication, those are all the most effective strategies. So I did a lot of talking. Any questions about what I talked about? So that's pretty much it from our end. I just wanted to really relay the message of the right therapies and trying to avoid a lot of the noise that we hear, especially with social media. It's amazing. Really, they're doing a disservice to the community where you hear a lot of it, because a lot of people will stop their therapies because of what they hear on social media. And they come to you later on and they've had a problem. It's a lot of times just from avoiding the right therapies. So, but thanks for showing up.
Thank you.
Thanks, no problem.